This whole narrative of do whatever you can do to become thin is completely false because there is a concept called thin on the outside, fat on the inside, TOFI. It's a real phenomenon. It actually has a scientific name, metabolically obese, normal weight individuals. The MESA study, it's one of the largest cardiovascular cohort studies, showed that the visceral fat volume predicted cardiovascular events independent of your BMI or your waist circumference. The visceral fat also secretes pro-inflammatory molecules. This inflammation quietly damages the blood vessels, and when there's a damage, LDL goes to stick on it, and this keeps going on and on and on, 10 years, 15 years before any lab value becomes abnormal. Standard blood panels were designed to detect disease, which is already established. They are not particularly good in detecting metabolic dysfunction that precedes the disease by a decade or more. Don't have your goal as a number on a scale. The goal is to have a body that functions beautifully, that has energy and resilience and ages gracefully.
Welcome back to Infinite Health. One of the core ideas of this show is that the most important health risks are often the least visible. And today's topic is a perfect example of that. Weight has become the default way that people really judge their health. But as you've explained many times, Arasi, the number on the scale often hides what's actually happening metabolically. So today we're talking about visceral fat, not as an appearance issue, but as a biological signal that quietly drives long-term cardiometabolic risk. So I think definitely we are constantly judging our health by our weight. It's something that people think about all the time. So I'm excited to really hear a little bit more about this from your lens, So nice to see you again. Excited to dive into this with you.
Thank you. Yes, it's one of my favorite topics. It's such a it just misleads people so badly, and we've become obsessed with this number on the scale. So yeah, let's jump right into it.
Absolutely. So with talking about that, why do you think that weight became the primary proxy for health to begin with in the first place?
Well, it just became our shorthand for health for one simple reason. It's easy to measure. You get on the scale, it gives you a number, and numbers make us feel smart and makes us feel objective. So the body mass index came on. It honestly was designed in the 19th century as a population level statistical tool. It was not designed for any clinical use or a diagnostic use or any of that. It was a statistical tool. But in medicine, we needed a fast, cheap screening number, and BMI just filled the role and it stuck. And there's also a cultural layer, right? In the Western societies, thinness became synonymous with discipline, health, and even moral value. So when someone looks thin, we unconsciously associate that with being healthy. And they are hardworking and they have a level of discipline. And if someone is heavier, we automatically say, oh, this person is unhealthy. They are probably lazy. They're not going to do their job. These are just dangerous, completely wrong assumptions. Science has moved beyond the scale. It's almost like we are stuck to the generation 1 iPhone when we have iPhone 17. So that's how talking about a number on the scale is so redundant right now. We now understand what metabolically matters is not your weight, but where your fat is stored and how your body processes its energy. So completely different questions. The numbers on the scale is neither reflective of your health or reflective of where you store your fat. It's a blunt instrument. The human body deserves more precision than a single number. And today we have those tools that offer that.
Absolutely. And what you said about assumptions about people's health based on their weight can be so inaccurate. It's so wrong. Just because someone may appear heavier, it means, like you said, they're lazy or they're not going to do what they need to do. And it's completely untrue. So, what do you think really created that narrative? Like, what gets missed when people assume, for example, thin automatically means healthy?
It's because initially, the doctors also talked about weight, 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 weight. And we didn't focus on what kind of weight. We didn't focus on health. Instead, we focused on you need to lose weight. You
Mm.
need to lose weight. And that narrative kept, going around and going around. And uh, this is pre-social media. Movies and Hollywoods and Bollywoods and all the different cinematic movie industries did not help us. The fashion industry did not help us. We created a generation of ultra thin supermodels who, just because they were thin, they were taken it, so all kinds of social determinants which just propagated this false belief that thin equals being healthy, which is not true at all.
Absolutely. And some people, just going back to even like the social aspect, some people do so many unhealthy things to be thin to appear healthy. It's such a backwards way of really even thinking about things, but I think it's become such a big part of the social norm almost.
Yes. I mean, if you remember, when cigarette smoking was a popular thing and they realized nicotine suppresses appetite, they used to have doctors wearing white coats come on television and talk about how smoking controlled their appetite and therefore made them thin. Without when we did not know all the harmful effects of smoking. So this whole narrative of do whatever you can do to become thin is completely false because there is a concept called thin on the outside, fat on the inside. TOFI. It's a real phenomenon. It actually has a scientific name, metabolically obese, normal weight individuals.
Wow.
You look
Heard of that.
surprised.
Yeah, I have not heard of that, but I just think that I didn't know that that was an actual, concept, but I know it is something that exists to an extent, right? The way you look and the way your health actually don't particularly align. And I'm sure you've seen this, so I'm curious, how often do you actually see patients who may appear healthy on the outside, but carry significant metabolic risk?
A lot, unfortunately. And they are the toughest patients from a cardiovascular standpoint. They almost have very brittle disease, right? They have very less muscle mass, okay? And they have skinny arms, skinny legs, very heavy, very dense belly. And that belly is filled with visceral fat. And what happens is that the internal organs are all carrying the load. The liver is fatty, the pancreas may be surrounded by lipid deposits. The blood vessels are heavily inflamed. It's a sign of inflammation. And it's just these patients are very hard to treat because the blood vessels, I always compare blood vessels should be like a nice bendy straw, like, very flexible and agile. But these patients will have PVC pipes, kind of like, very hard, very calcific disease. And you have research supporting that too. Studies which used CT based body composition found that a significant portion of the normal weight individuals have high levels of visceral fat and which are the metabolically risky range. The MESA study, it's one of the largest cardiovascular cohort study, showed that the visceral fat volume predicted cardiovascular events independent of your BMI or your waist circumference. But there is, inspiring part of this theory is that we can find these people before events happen. We have tools. We just need to be more proactive about, looking for it and going after it before we rely instead of relying on BMI or the scale alone.
Absolutely. And I always remember even, going to the doctor's office and seeing this BMI scale and saying like, if I weighed what this says, like I would not feel like I would even, be healthy, because I think that maybe this was created also a long time ago, and things have also, I think, changed around like BMI and scales and just the way, our health is measured. But what distinguishes, visceral fat from subcutaneous fat at a physiological level?
Oh, okay. Fantastic. Think of fat in your body as having different zip codes, okay? Or your postal code, okay? And where your postal code is going to determine everything about you, like which school you go to, which restaurants are available to you, your neighborhood, etc. So, and your behavior is kind of, that's why we want we choose good neighborhoods and things like that, right? So subcutaneous fat is the fat you can pinch. It's just under the skin of your arms, your thighs, your hips, etc. It's just this pinchable fat, right? It's very largely inert, metabolically inactive fat. Okay. Your body uses it as a long-term energy reserves. It's mainly protective. So let's say there's a famine which happens and you don't have any access to food, your body will start utilizing this fat for energy, and a higher amount of subcu fat, particularly in your hips and thighs, actually lowers cardiovascular risk, and it offers you a genetic advantage. That's called the obesity paradox. These are the obese patients, even in the ICU, when they're critically ill, do better because the fat is being used for energy. Okay, this is the pure shaped body fat. It's a good fat. Like thought to be in sumo wrestlers, at least some of the sumo wrestlers had the high levels of subcutaneous fat. Then comes the visceral fat, which is completely different. It sits inside our abdominal cavity. It wraps around our liver, your intestine, your pancreas, your kidneys, and it doesn't just sit there. It's hormonally active. It's a metabolically aggressive tissue secreting chemical signals, adipokinases, cytokines, inflammatory markers that just get directly dumped into your portal circulation or your liver circulation, and then finally into your bloodstream. So all your major organs are kind of sitting in this inflamed milieu. And the difference is not just anatomical location of the body fat or how you look, it's what it is doing inside. The same molecule, depending on where it lives, behaves completely different. So your body's geography matters as much as your zip code as to where you're living. And understanding where your fat lives, not just how much is there, that's where the modern metabolic medicine begins.
And why is it that you think visceral fat is so metabolically active and, harmful over time?
It has a higher density of certain receptors, right? It has higher cortisol receptors, beta adrenergic receptors, which makes it more sensitive to stress hormones. And when you're chronically understressed or deprived, the visceral fat responds by releasing free fatty acids into the circulation at a higher rate for metabolism than the subcutaneous fat. And these free fatty acids, it's a mouthful, travel to the liver, disrupts its ability to regulate glucose and lipid metabolism. And this leads to insulin resistance. And the liver stops listening to the insulin signals properly. And as insulin resistance keeps progressing, pancreas compensates it by producing more insulin. And then over time, your blood sugar remains normal, but your pancreas is working very hard and it can't take it anymore and it breaks down. And when it stops and it breaks down, glucose starts to rise. At the same time, the visceral fat also secretes pro-inflammatory molecules, TNF alpha, IL-1, resistance, these are all names, but these are all inflammatory cytokines, which creates a chronic inflammatory state. This inflammation quietly damages the blood vessels. And when there's a damage, LDL goes to stick on it. And then as a part of the healing process, calcium deposition happens, and the endothelial function, or the innermost lining of your blood vessel cells, they start functioning abnormally. The blood vessels, instead of being nice and pliable, are stiff. They don't have the ability to relax or regulate flow. And this keeps going on and on and on, 10 years, 15 years before any value becomes abnormal. The damage has been silently going on. So, according to the ACC/AHA 2019 primary prevention guidelines, recognizing insulin resistance and chronic low-grade inflammation are the key pathways in reducing your atherosclerotic cardiovascular disease, and both of them are downstream products of visceral adiposity.
And why or how does visceral fat contribute to cardiometabolic disease even when the standard labs look normal?
Yeah, that's the piece that surprises most people,
Mm,
right? It's critical for non-medical audience to understand. Standard blood panels were designed to detect disease, which
mm,
is already established. They are not particularly good in detecting metabolic dysfunction that precedes the disease by a decade or more. Okay, your fasting blood glucose of 94 technically normal, but it represents a person's who insulin is running 3 or 4 times the level it should be. Okay, just to keep that number at 94. Blood glucose is 94, but buckets and buckets of insulin are being secreted to keep the blood level of 94. That's not normal, right? So the hyperinsulinemia doing the damage in the background does not even come through when you just check a fasting blood sugar. Same is true for cholesterol also. Patient might have a total cholesterol of 185, textbook normal, but if the HDL is low, HDL is the high density good cholesterol, and the triglycerides, the big fatty fluffy particles, which is elevated, then they have an atherogenic dyslipidemia, and their cardiovascular risk is much higher than the total cholesterol number. So that pattern, low HDL, high triglycerides, it's a fingerprint of visceral fat and insulin resistance. So when someone comes to me and says, my labs are normal, I am fine. And I'm like, I appreciate, you are feeling comfortable. But if you want me to look deeper, I can look deeper for you. Normal is not the same as optimal. And optimal levels is where prevention lies. So normal is defined by average population ranges, right?
mhm.
For I am not an average person. You're not an average person. You are you and I am me. So we have to aim for, I don't want average health. I want exceptional health. And so that requires a higher standard of measurements.
Mhm. And that's even almost a little bit about still auditing yourself, like we've talked about in previous episodes too. And that's your why. You want your excellent health. So even this, in a way, still kind of comes back to the why we've mentioned in previous episodes too. But when it comes to you evaluating a patient, how do you assess visceral fat risk in real world practice?
So I use a layered approach. I start with simple and accessible and then go deeper based on the clinical picture. The first thing I do is waist circumference. And my staff was like, what? I said, yes, you actually have to go get a measuring tape and start measuring people's waist circumference, not weight, not BMI. Okay. The risk thresholds per ACC/AHA guidelines are greater than 40 inches in men and 35 inches in women. This is for non-Asian population. But for the South Asian, East Asian, Hispanic ancestries, those thresholds are much lower, 35 and 30. And this matters because visceral fat accumulates at lower BMIs in these populations. Then I look for, specific metabolic signatures in the blood work. Fasting triglycerides, HDL, triglycerides to HDL ratio is very powerful, very underused, but it's a phenomenal marker for insulin resistance. A ratio above 3 in a non-Hispanic white or black community is concerning. HDL to triglycerides to HDL ratio above 2 is abnormal in an Asian population. Fasting insulin, not just glucose, hyperinsulin levels, insulinemia. My God, sorry about my tongue stuttering here, precedes glucose level 10 to 15 years. Okay, uric acid levels. Elevated uric acid level is a marker of your fructose metabolism. And we are all, exposed to high fructose corn syrup all the time. And that often tracks with your visceral fat accumulation. High sensitivity reactive protein, a marker of systemic inflammation that visceral fat actively promotes. So, for patients where the clinical picture warrants it, particularly if they're high risk cardiac patients like my patients, I will go into coronary calcium score, cardiac CT, body composition analysis, in body scans or DEXA scans for visceral fat measurements. There are multiple tools which allows us to see beyond what the scale can show. So, yeah.
Hmm. And speaking about that, what other markers actually tend to travel alongside elevated visceral fat?
Yeah, visceral fat is a misery that loves company and never travels alone. It's a part of a constellation we call metabolic syndrome. But I can think of a less as a syndrome, but more of a biological story that unfolds in real time. The classic cluster is elevated waist circumference, elevated triglycerides, low HDL cholesterol, elevated blood pressure, elevated fasting glucose. When you have three or more of these present, we call it metabolic syndrome. And the cardiovascular and diabetic risk is substantially elevated in these patients. But beyond the formal criteria, I also look for fatty liver. Okay, on liver ultrasound or fibroscan, we now have a new term called metabolic dysfunction associated steatotic liver disease. It is basically abnormal metabolism and fat deposition in your liver. It roughly represents 30% of the general population, and it's tightly linked to insulin resistance and visceral adiposity. Sleep apnea. Again, visceral deposits around the upper airway contributes directly. And sleep apnea in turn worsens your cortisol and insulin resistance, creating this feedback loop. You've caught the tiger by its tail, and there's no way out of it unless you make actual decisions to change your life. Polycystic ovarian syndrome in women, strongly linked to insulin resistance and visceral fat accumulation, and a major under-recognized cardiovascular risk factor. Then something as simple as lot of skin tag, hyperpigmentation of your neck, your underarms, darkening of your skin folds, acanthosis nigricans is a scientific term, which are signs, physical signs of chronically elevated insulin levels. So when I see these markers all traveling together, I am seeing, different, the metabolic dysfunctional set of symptoms going together, and they're all giving each other company. And each one of these markers is truly modifiable. And that's what makes this hopeful. Okay, the good twist to this story. It's not ominous, but we can actually make a change, a meaningful change.
And it's like you said, I think that there were so many things that you said travel together. So it's not just one in particular thing. And just on my knowledge, even just on PCOS, because I've struggled with PCOS, it's very complex. It's complicated. It's complex to navigate and figure out. But now hearing that all these other factors contribute together makes more sense. It's complicated to really understand how it all works together for someone who isn't knowledgeable. So hearing this is really helpful to like understand how everything fits together and like travels together. Like, it's gonna stick with me. Uh, why do you think that visceral fat, or what do you think of visceral fat as a signal rather than a diagnosis? Because it's
Yeah,
a diagnosis, right? It's not.
sure. It's a complicated question because a diagnosis for me is fixed. Like, you have coronary artery disease. That's a diagnosis,
Yeah.
right? But visceral fat, increased visceral fat, it implies, it gives me uh, a signal that this information, I can do something about this information. It gives me agency and it gives patients agency also. So when I tell a patient that visceral fat profile suggests metabolic stress, I'm not telling them they are sick. I am telling them their body is communicating something important to them, and that we caught the message early enough that we can do something meaningful about it, which can make their future life better. The biology of the visceral fat is remarkably responsive, like other many cardiovascular risk factors. Visceral fat responds quickly and dramatically to targeted lifestyle changes, often within weeks to months. And patients can see measurable improvements in their metabolic markers before they have lost significant weight on a scale. So that's a profoundly empowering message. You don't need to wait for a diagnosis. You don't need to wait for a crisis. You can act on the signal right now and you can change your trajectory entirely. So, visceral fat is your body asking for something: better sleep, less chronic stress, more movement, different fuel. This is a signal. It's not a verdict. It's an invitation. This is a cry for help.
And speaking about acting on it, right? What interventions actually reduce visceral fat in a way that's sustainable?
The evidence in this area is genuinely exciting because it's, as I said, it's very responsive, right? And I'm an interventional cardiologist and I love instant gratification. And when I do the right intervention, it works fast and it's very exciting. So with the right interventions, patients can expect faster result. But there is a hierarchy in which you have to go through, okay? And based on the strongest evidence, here's my hierarchy. Resistance training, most underrated intervention we have. Build your lean muscle mass. That fundamentally changes how your body handles glucose and insulin. Muscle is metabolically hungry. It draws the glucose out of the bloodstream and creates what we want: metabolic flexibility. 2 to 3 sessions per week, progressive resistance training in multiple randomized trials have shown to reduce visceral fat without any significant change in your body weight. Okay? Number one, go to the gym. Don't have a gym, do body weight exercises. The YouTube is filled with free programs for resistance training, and you don't need just big bulky weights. The bands are good enough. Using your own body weight you can train yourself. Calisthenics, fantastic. Next, dietary pattern, not a specific diet, okay, but patterns that reduce insulin load and fructose intake, reducing ultra processed food, added sugars, refined carbohydrates. They have a disproportionate impact on visceral fat because they drive insulin spikes and fructose driven hepatic fat accumulation. That is, I have eating an apple versus eating a candy bar. Both are sugary, okay? But with my apple comes fiber, which does not create an insulin spike, whereas a candy bar creates an insulin spike. So a Mediterranean style or whole food dietary pattern has the strongest cardiovascular evidence base. Okay. Number 3, sleep quality and duration. This one is very underestimated. We don't talk enough about it. And as a doctor, I am guilty of it. I was on call this weekend. I did not get good enough sleep. So, I'm running on a sleep deficit. So even partial sleep restriction, that is sleeping 6 hours instead of 8, increases your cortisol levels, elevates your ghrelin, the hunger hormone, suppresses your leptin, your satiety hormone, and drives visceral fat accumulation. You cannot out-exercise a chronically sleep-deprived metabolism. So I had a busy weekend. I didn't sleep well over the weekend. I need to have a lighter day today. I need to, rest my body a little bit more. So that leads into my next one: stress regulation. Chronic stress drives cortisol elevation, and cortisol is one of the most potent triggers of visceral fat. Mindfulness. I always talk about my favorite calm apps or Headspace or Yoga Nidra, breath work, nature exposure, social connection, not social media connection, social connection, hanging out with besties and best friends. These are not like soft touch points. These are not woo-woos. These are not, they are biological interventions with measurable effects on cortisol and metabolic health. And then in appropriate patients, medications, GLP-1 receptor agonists, which we have discussed in our previous episodes, they have demonstrated specific reductions in visceral fat and hepatic fat beyond what's expected from weight loss. So here you go.
Absolutely. And I think one thing you also touched on earlier was, you want that instant gratification. So where do people go wrong when they have to target visceral fat directly? And I know some people, even we spoke about this in the last episode, want to take a GLP-1 to maybe lose 20 pounds fast and not go about it the right way. But where do people really go wrong when they're trying to just target that one visceral fat directly? It can happen quickly.
Yeah. So the thing is, when we say visceral fat, we're talking about fat around the abdomen. So immediately people are like, oh, I'm going to reduce my visceral fat. I'm going to do 1,000 crunches, and therefore my belly fat will shrink. It doesn't work that way. There is nothing, no spot reduction method. You cannot selectively burn fat from one area of the body and spare the others through local exercise. And you can't, freeze the fat in your belly and think you are doing something to your metabolism. You cannot do that also. You have to change your systemic hormonal metabolic environment. And that is where fat is going to be stored is going to be determined. Okay. The second major error is going to extremes, crash dieting, extreme caloric restriction, or high intensity exercise without recovery. And these approaches all spike cortisol, and cortisol is provisceral. You can actually accumulate more visceral fat while trying to do these drastic calorie restriction and things like that. Because if you're chronically stress activated, that's what is going to happen. So that's why people who are perpetually dieting and restricting don't see metabolic improvements, okay? But actually, this up and down matter cripples their body, and they put themselves at a higher risk for cardiovascular events because of that. Then the third mistake is going to be sleep and stress. I cannot, I could just go on and on and about sleep, 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 and stress management. It's very difficult. On a personal note, it's a very difficult journey for me because I live in 7, 8, 9, 10 out of 10, and I had to intentionally move my brain and my excitement level to 3, 4, 5 is good. And still be truthful to myself and still recognize Arasi as Arasi, right? Because Arasi is this passionate person, blah, blah, blah. But can I still be 3, 4, 5 and still be Arasi? So again, look in the mirror and see what's working for you and which is not working for you. And, don't chase the scale. Don't chase the number on the scale. Chase metabolic markers. I mean, I know in your 20s and 30s, it's like blasphemy to go and visit a doctor and actually sit down with them and talk about what's working or talk about their lifestyle because you have deadlines and you have, board meetings and whatever. But your 50-year-old self will thank you for if you actually go spend time with your doctor and kind of get a holistic assessment of how healthy you are in your 20s and 30s.
I think that is so important. I know I was on another podcast and they were talking about your 40s and your 50s and wishing you had taken care of things in your 20s and 30s because you're building on longevity versus trying to go back and fix things that if you just made small changes earlier on, you'd have such a better quality of life later on. And with aging, I know we talked about this a little bit, but aging and the quality of life. You can live to be, much older, but if you're not able to move around and walk, it's the quality of life is so diminishing. It doesn't, you got to do both. But,
Absolutely.
mhm. And what would you say that listeners should stop fixating on and start really paying more attention to instead?
Okay, great question. Stop fixating on the number on the scale. Stop fixating on your BMI.
I knew you
whether
were
your
gonna say
total
that. I was like,
cholesterol is 200 or how many calories you burnt out,
mm,
none of that matters.
mhm,
Start paying attention. Did I have a good night's sleep? What is my resting heart rate over the past month? Am I am I reducing my resting heart rate over time? What is my energy and mental clarity? What is my triglycerides to HDL ratio? What's my weight circumference? How do I feel 2 hours after eating? Am I sleepy? Am I in a post food coma? Or do I have energy? Because if you're in a post food coma, you probably have insulin resistance. So, those are the things you need to kind of focus on. How much, it's not the weight of the number of pounds you can bench press, but can you actually be bench pressing and do a 5 minute run and do have mobility exercise? Are you are you flexible? Is your metabolism flexible? Those are the things you need to focus on. I truly want people to shift from a weight loss mindset to a metabolic health mindset. Weight loss is just an outcome, whereas metabolic health is a state, and it's a state you can actively build. You can become more insulin sensitive. You can build more metabolically active muscle. You can improve your inflammatory profile. You can reduce your biological age of your cardiovascular system. And none of this requires you to hit a target weight. They require to make different choices that your body responds to. So the most empowering thing I can tell you is the biology is on your side. We as human beings are built for survival. The body wants to survive. It's remarkably adaptive. And when you give what it needs, real food, real movement, good sleep, uh, it moves towards health. This is not motivational language. This is just mechanistic science here.
mhm. Absolutely. And I think that, talking about visceral fat, people might hear it and think about it and kind of panic a little bit. But, visceral fat isn't something to panic about. It's something to just understand. And when it's viewed correctly, it becomes information, not judgment. And it gives you the opportunity to intervene earlier, more calmly, and more effectively. So, this is what long term health really looks like: paying attention to quiet signals, making steady changes, and focusing on outcomes that compound over time. So, thank you so much, Dr. Moran. I think that this was such an informative episode, as always.
Don't have your goal as a number on a scale. The goal is to have a body that functions beautifully, that has energy and resilience and ages gracefully. And that is the vision metabolic medicine to, look forward to.